that they be blocked, and it cannot be published review like it is for national coverage decisions. Many of these NCDs will focus on new molecular cancer diagnostics and imaging studies. Some will be on procedures like vertebroplasty, which benefited a few patients and a select few, but those that benefited from chronic pain in the spine with things like compressed vertebrae with multiple myeloma, it was real. There are also going to be problems with getting individual patient exceptions with local coverage decision. As a result of MACRA, what we're going to do is have to spend more time for documentation, and this is going to be particularly true for the longitudinal care providers. As I said earlier, orders will need to be linked to diagnosis, and issues affecting outcome will be a problem for patients because we'll have to document patients with mental health disorders and all these other things, which patients will get to see their problem list, their notes right away. They may not agree or want that there. And this is a problem, and yet, while the patients own their notes, we are the authors, and we need to have the ability to reflect things that affect care outcomes, but also, the most fundamental use of a progress note is to provide information in case something happens to you as a provider so that another person can assume care and know what you know about a patient. With E&M, I've been a great pusher and promoter of the new E&M reforms, the new care management codes. We will see increased use of prolonged services. The proposal that's just come out in the final rule to be implemented in a year is we will measure things on total time rather than face-to-face time. And the level determination for an E&M service will be on medical decision-making. What the reform efforts have not done, which is unfortunate, is deal with the fundamental difference in an evaluation and management service that is different when it's used by a proceduralist versus someone engaged in longitudinal care management. E&M services are completely different for those two folks. Our surgical globals and E&M documentation remain a problem. A recent RAND survey that was done showed only 1% of the post-operative E&Ms are being documented in the chart. This is available at CMS. And this is also sadly available to Congress. And it created a problem. Our bigger problem, as most of you know, is physician burnout. The solutions for MIPS and APMs will worsen our burnout. Our burnout rate is 60%. New codes to help pay for cognitive care or chronic care services, we've got them now. It would help physicians' revenue stream. The documentation rules are not all that onerous, but burnt out physicians working hard are not willing to do any more iota of documentation, even if it results in more salary. Prolonged service, non-face-to-face for 30 minutes between an E&M service on a different day pays 2 RVUs. That's better than level 2 or 3 and almost level 4 E&M service outpatient. Our employed physicians will have high scrutiny on their high-cost patients, which will be a problem. And non-compliant patients may retaliate on documentations of reason for their outcomes being problematic. Potential good of reform, if it helped, we all know we need better care coordination between inpatient and outpatient venues. This would be a good thing. I think it probably will necessitate more scrutiny of costs, such as the site of service disparity between surgery centers versus outpatient hospital surgical facilities. Now, whether or not when we do the site of service disparity, we deal well with the patient who has more comorbidities that we can't send to a surgery center, that you need the increased resources of the hospital, need a hand in how you deal with those costs, unclear. I think if we can get to comprehensive granular coding, it would be a good thing. It will help us better understand the drivers of healthcare costs and claims. Because reality, the only place anybody's ever going to look for costs is going to be in claims data. I also believe that some of the new E&M service, paying physicians for the real services they do is better in the long run. All payers need to better understand how physicians use their time in care of patients. Sadly, even for if you take the alternative payment model and go at risk, you're still going to have to document the CPT codes, because that's basically how Medicare audits that the payment is warranted. So the moral dilemma, I don't know if any of you were here when Richard McCormick, one of the first Jesuit bioethicists in this country, taught at Notre Dame. Dick McCormick was a very good friend of mine. He spoke that the practice of medicine will always continue to live in a dialectical tension between distributive justice and the common good. You know, when I talk to people about costs and rounds, everybody says, well, I don't want to deal with those allocation issues. Reality is allocation of resources that are fixed and finite are not new for medicine. When I round on inpatient, how I allocate my time that day is based on the acuity of the patients. So we live this tension all the time. Our responsibility will continue to be in tension between the duty to an individual patient and our duty to society. It's very easy to identify faults with MACRA, and God knows I've been on the lecture circuit for a year and a half talking about that. But our current U.S. health care expenditure is unsustainable, and nor is our health care rationally or equitably distributed in society. As a profession, I do believe we must find the ethical tools to be healers of individual patients and of society. And if healthcare usage is to be rationed, it must be rationed fairly and not simply by denying care to the most vulnerable. I really worry that the most vulnerable patients, those with advanced complex diseases, multiple diseases, poor social situations, and mental health disorders, are highly at risk for becoming very undesirable patients and will have access to care. We as physicians must be the strong advocates for access to care for our patients, particularly the most vulnerable. Normally I stop with that slide for this talk, but because this is where I went to school, where my values were formed, I need to bring in the theology I learned at this institution to end this talk. My answer for human suffering, and I've had to deal with a lot of unforgivable suffering. As a young intern, I dealt with a 40-year-old woman who was mentally disabled, left in various skilled homes, was raped repeatedly in these skilled homes, then had TB, got the old ping pong balls in the chest, and was going to die a horrendous death of pulmonary hypertension. Her suffering really bothered me. You know, but the answer is Christ was God's intimate involvement with humanity. And the Christian love is an intimate sharing of a life journey with suffering. Our ethics as a Christian are written in the Sermon of the Mount. Christian medical ethics are not relativistic like Fletcher's situation ethics. The Sermon on the Mount is very clear that we must serve the most vulnerable, for that is where God lives. In my era here, Jean Vanier and Henry Nouwen were essential reading in numerous courses, as well as in various of the adored homilies. Vanier was interesting because he taught me that to look at the vulnerable, that they often have as much to give us as we give them. I have a permanently disabled daughter who is the joy of my life. My dying patients probably have been the best teachers about how to live. Nouwen wrote a book called The Wounded Healer. I love the title. The language is now somewhat sexist. But we are called to reach out to others as physicians, even when we are hurting and imperfect. Courage is holding hands even when you are in pain. In Christianity, we both have the pain of Calvary and the hope of Easter. A person, Gregory Baum, also gave me some of the intellectual tools to process this dialectic tension in his two great books, Man Becoming and Religion and Alienation. Again, the books are sexist in language in this modern era. There's a wonderful friend of mine here who was assistant director of campus, or deputy director of campus ministry in my youth, Jane Pitts. Jane commented to me even when I was young, I was pretty good with words. But she said sometimes words can't really describe something for us. We need an image. And you know, the many times I felt like Mary. How do you deal with the unforgivable, the unfathomable, when she was holding Christ's dead body after taking off the cross as so eloquently in various Pietas by Michelangelo Mastrovic. My answer to that image has always been St. Thomas examining the wounds of Christ, but let us focus on Christ as in resurrected glory, still carrying the wounds of Calvary. He was the ultimate wounded healer. You know, I believe, though, this is the modern era, and, you know, lately the church and all of us have rediscovered Mary Magdalene. And, you know, it's moving our male-centric church into much more diversification, something it desperately needs. Thomas Aquinas described her as the apostle to the apostle. But unlike any of the male disciples or apostles, she had the courage and love to stand at the foot of the cross. She also was willing to risk everything and still visit the tomb to honor the dead body. None of the males did that, not even St. John. And she had the courage to believe and hope and be the first to witness a resurrection and teach the others to believe. So I hope what we took from our theology course is that we will find, despite all these pressures, we will find the courage to do what is right despite the cost. And I think the cost for us as healthcare providers will be greater in the future than it has been. Thank you.